Good evening, everyone. I would like to thank you all for taking out your precious time from your busy schedule. This webinar is organized by Banai, Behavioral and Neurosciences Academy of India. Banai is a not for profit organization formed in 2012 and has organized more than 200 plus programs nationally and internationally. Focus of Banai is to provide contemporary cutting edge on behavioral neuroscience. Banai is formed and runs under the guidance and chairmanship of Dr. E Mohandas. Banai welcomes everyone and anyone who is interested to join. It gives me immense pleasure to introduce Dr. Avinash D'Souza as the moderator for today's webinar. Thank you, Dr. Avinash D'Souza, for accepting to be the moderator for the webinar. Dr. Avinash D'Souza is a consultant psychiatrist and founder trustee of D'Souza Foundation. Dr. Avinash D'Souza is the Honorary Secretary General, Indian Association of Private Psychiatry. Dr. Avinash D'Souza has over 750 publications in national and international journals and is the editor Indian Journal of Mental Health and Annals of Indian Psychiatry. Dr. Avinash D'Souza is the associate editor of Industrial Psychiatry Journal and Global Bioethics Inquiry. He is also the assistant editor of Indian Journal of Psychiatry. I would now request Dr. Avinash D'Souza to take over and start the session proceedings. Over to you, Dr. Avinash D'Souza.
Good evening, everyone, and it's an absolute pleasure from our end to have all of you here. Today's session is the 13th of our talks from Banai, and it's a very, very important, prestigious, personal session for all of us because today's session is being held in honor of late Professor Dr. Charles Pinto, who left us just a few days ago, which was very tragic and shocking to all of us. Today's session is specially being held in his honor because Dr. Charles Pinto is a name that everyone knows in the psychiatry, mental health, and gerontology world. He's someone who has done tremendous work in geriatric psychiatry and dementia. He worked at the Holy Family Hospital in Bandra, where he teamed up with Dr. Chico Vaz, who was a neurologist, to do path-breaking work in geriatric psychiatry and dementia, which has been recognized internationally. Dr. Charles Pinto has also been a past president of the Indian Association of Geriatric Mental Health. He's loved by all of us, especially as a very well-known, erudite, simple, well-spoken, well-learned postgraduate teacher in Mumbai. All of us who have studied in Mumbai have been through his tutelage at some point of time and have learned so much from him. In fact, I always remember during my residency days, nearly 2 decades ago, it would always be an immense honor and a pleasure to present a case to Dr. Charles Pinto because there would be so much of learning that would come out of it. I personally have known him, of course, as a student, personally known him because he knew my parents well. But most importantly, he's always come across as someone who's very learned, very experienced, very humble, very approachable, and who's come up from humble beginnings to where he was. And we definitely adore him, respect him, cherish him. And today's sessions are a tribute to him. It's a small tribute from our side, what we could offer in his honor. Uh, the topics are, of course, on dementia. And I will now hand over to our chairpersons, Dr. Bhaskar Mukherjee and Dr. Rajesh Nagpal. I will first introduce them. Dr. Rajesh Nagpal, we all know, is a consultant psychiatrist at New Delhi, and he is also part of the Sarvam Neuropsychiatric Centers. He's also director at Banai, India, and a professor at the International Institute of Organizational Psychological Medicine and the past president of the Indian Association of Private Psychiatry and the Indian Association of Biological Psychiatry. Dr. Bhaskar Mukherjee needs no introduction in the neurobiological world. He's, of course, dealing with the full working of the brain, and molecular biology is where he feels most comfortable. That's where I feel a little uncomfortable, but he is most comfortable over there. He loves to understand and evaluate the pathophysiological basis of psychiatric symptoms, both macroscopically and microscopically, going from connectomics to genomics. His interest areas are treatment resistance in psychiatry and trans diagnostic understanding. And his life's goal is to make psychiatry regain its spot in medicine. And I'm sure Sir would definitely make that happen. So over to y'all, and I will be there to moderate the question answers. The both our speakers would speak first, and I would then manage the question answer session after that. Over to Dr. Nagpal and Dr. Bhaskar.
Thank you very much. Good evening, everybody. We should start without further ado. Of course, it's an honor of Charles, a great friend of all of us. So I would now request Dr. Mohandas to start with a very specific topic in dementia, something which Charles would have loved to hear, disease-modifying agents in dementia. We are aware that most of the current drugs are not disease-modifying. We have some in the pipeline. Dr. Mohandas, who else but Dr. Mohandas can tell us more about it? Dr. Mohandas, please start. Dr. Mohandas, as we know, he will wear various hats. He's very popular. He's the most popular teacher among us, who's taught most of us informally and formally. So without further ado, let me ask him to please start the proceedings. That's what the audience is now
Rajesh,
looking forward.
Bhaskar would like to
Dr.
talk.
Mohandas, please.
No, Bhaskar.
Okay.
Bhaskar.
No,
Bhaskar,
sir.
yeah.
Sir, please go on, sir. Please go on, sir. We are going to listen to you talk.
Yeah, let me just share the screen. Yeah, dear Rajesh, Bhaskar Mukherjee ji, Anukant Mital ji, and my dear Avinash D'Souza, and my dear friends. I was asked to talk on disease-modifying therapies in dementia, but I will focus only on Alzheimer's. Mainly, I will not talk on FTD or Lewy body or anything, because Alzheimer's is the commonest one. This is the projected number of people aged 65 and older. This is the US population. What is happening in 2020? We have got US has got 5.8 million millions of people, but by 2030 it will become 8.4 million, and 2040 11.6 million, meaning it is always on the rise, and we have to be a little bit, we have to really focus on it. And this year, 2020, this is 2021 anyway, a 5.8 million, but majority of them are in 75 to 84 years, 2.7 million, and followed by 65 to 74 years, 1 million. And 36%, if you are older enough, and you are likely to get it. Now, what is Alzheimer's disease? Everybody knows it. It is classically described as extracytoplasmic amyloid deposition. You can see the bullet. And also, you have got the neurofibrillary triangles that it's intracellular. You will have the dystrophic neurites and area-specific degeneration of cerebral neurons, but ultimately it happens altered cortical connectivity, and lastly the synaptic failure. So what happens? This is the amyloid plaques, and these are the neurofibrillary tangle. That is the amyloid tau hypothesis. Both. What happens? Production release of beta amyloid microglia is activated by the diffuse beta amyloid. There is a cytokine release, then extracellular diffuse amyloid deposits, pathological chaperone ApoE and ACT are synthesized. Amyloid plaque formation is accelerated. Mature amyloid plaque and reactive astrocytes, and then the neurofibrillary tangles induced in dying neurons. So, defective APP synthesis and release of beta amyloid, inflammatory response to diffuse amyloid, and amyloid plaque formation and neuronal death. Multiple causes have been proposed for the toxic amyloid accumulation and tau hyperphosphorylation, genetics, epigenetics, oxidative stress hypothesis, neuroinflammatory hypothesis, metallotoxicity hypothesis, neurovascular hypothesis, hormonal or metabolic hypothesis. Metabolic means including diabetes, type 2 diabetes mainly, that will result excitotoxicity and cholinergic deficit because of the presynaptic cholinergic deficit. Now, when we think of disease-modifying therapies, when will we start a modification? You have to modify the risk initially. You just see this Lancet Commission report in 2020. I think it is now published. If you see the early life, lesser education, if you control it, you can reduce dementia by 7%. And this percentage it is given is you can reduce the percentage of dementing people, hearing loss, traumatic brain injury, hypertension, alcohol, heavy alcohol use, obesity, and then smoking, depression, social isolation, and etc. So 12 modifiable risk factors account for around 40% of the worldwide dementias. And it may be theoretically prevented or delayed. But how early is early? Very difficult to say. The potential for prevention is high and might be higher in low-income and middle-income countries where more dementias occur. Just see here, hearing loss, traumatic brain injury, hypertension, alcohol, heavy use, and obesity. I mean, we can reduce these percentages. Because if you control this, you can reduce dementia by 8%. Another set of risk factors, depression. If you control depression, you can reduce dementia by 4%. Same is with diabetes and you have physical inactivity. These are, you can try to potentially modify. Potentially modifiable 1 or 40%, but risk unknown. There we are, 60%. We do not know. But I would like my friends to read this beautiful article by Livingston, which has come in Lancet 2020. Now, there was a systemic review and meta-analysis of 243 observational prospective studies, 153 RCTs. This also I would like my friends to read. It has come out in Journal of Neurology and Neurosurgery Psychiatry 2020. Class 1 suggestion targeting 19 factors, 10 factors with a level A strong evidence, education, cognitive activity, higher body mass index in late life, hyperhomocysteemia. Currently, people are focusing on it because this can produce folate deficiency, etc. Treatment is folate supplementation that you know pretty well. Depression, stress, diabetes, trauma, hypertension in middle life, and even orthostatic hypotension. But weaker evidence, level B evidence, obesity in midlife, weight loss in late life, smoking, sleep, this is lack of physical exercise, atrial fibrillation, etc. Some are protective factors. So this has suggested This blue ones, for example, depression, hyperhomocysteemia, stress, hypertension, trauma, etc., that comes to level A, and others level B evidence. What about hypertension and Alzheimer's disease risk? Can produce microinfarct, it can decrease local cerebral flow, energy deficit, and also additional normal beta amyloid accumulation and oxidative stress. It can produce neurodegeneration and Alzheimer's. Inflammaging obesity will is one of the cause for inflammaging. It can produce metabolic cognitive decline. That is why we call it inflammaging. It can produce cardiovascular disease, type 2 diabetes, insulin-resistant cancer, etc. Can produce many pro-inflammatory cytokines, etc., and macrophage-derived factors. Mechanism underlying the therapeutic effects of type 2 diabetics, drugs on Alzheimer's, people really give metformin and even glimepiride. Some people have tried even lixisenatide, liraglutide, rosiglitazone. Some people say anti-diabetics will be anti-dementia drugs in the future, but so far evidence still very thin. But if you are a diabetic, better to treat it, or if you are a pre-diabetic, control it by other means. There are many molecular mechanisms which I will not discuss. Heavy smoking can increase the vascular risk factors and also the oxidative stress, one of the biggest lifestyle risk factors. What about depression? Is a risk factor for Alzheimer's, maybe an early sign or a prodrome of dementia and Alzheimer's. And depression occurring at the state of dementia and Alzheimer's is also documented. Elimination of depression is calculated to produce 4% reduction in dementia incidence on the population level, exceeding the estimated effects of hypertension, diabetes, obesity, or any physical inactivity. So depression, from a psychiatric perspective and a neurological perspective, it's an important target. What about lack of sleep, lack of circadian rhythm dysfunction? It can produce neuroinflammation and oxidative stress. It can activate microglia, activate the peripheral innate immune system, inflammatory cytokines may be there, and you can have even oxidative stress and neuroinflammatory. Both hypotheses are, they both will be involved in circadian dysfunction and sleep disorders. Sleep deprivation can increase total tau aggregation, and remember, you can have decreased lymphatic flow, can produce, but so the plaques cannot get washed out or degraded or cannot be thrown out. So you can have synaptic deficits and Alzheimer's. So sleep is important. And the important focus is obstructive sleep apnea, can produce intermittent hypoxia, sleep fragmentation, intrathoracic pressure swings. So it can produce it can produce neuroinflammatory changes and oxidative stress. And many people with OSA can have diabetes, hypertension, it's a risk factor, and cardiovascular disorders, and sleep, decrease REM, decrease slow wave sleep, etc. And you can have cognitive impairment, so you have to correct OSA. Some people say dietary factors are good, especially the Mediterranean diet, which is very rich in fatty acids, especially free fatty acids. So some people say it's good. That's why red wine, sulfur compound in garlic, low sodium or high magnesium, low oxidative stress and neuroinflammation, normal information processing, and increased longevity. Not only Mediterranean diet, Okinawa diet, even vegetarian diet rather than non-vegetarian diet, it will protect you. vegetarian diet, especially low oxidative stress, and it can improve your cognitive function. Recently, hyperhomocystinemia has come to the focus, and raised concentration of the biomarker phosphatidylcholine homocysteine reflects the functional status of three B vitamins, folate, vitamin B12, and B6. Relative risk of dementia in elderly people for a moderately raised homocysteine ranges from 1.15 to 2.5. Normal people. Attributable risk 4.3 to 31% if the homocysteine is high. It is a marker, so you can treat it. What about inactivity can produce dementia? So the exercise is recommended. Exercise can improve neuronal survival, neurogenesis, brain plasticity, angiogenesis, and improved cognitive function. And it can also indirectly benefit your obesity, your diabetes, etc. And exercise will increase cerebral blood flow, ample volume, and this is written as aging research reviews in press in 2020. It is just published to my knowledge. What about the exercise? Aerobic, 2 a day, at least 10 minutes of moderate activity, or even resistance exercise on 2 days, Tuesday or Friday or any of the days, include exercise and daily activities. The physical activity should be recommended to adults with normal cognition to reduce the risk of cognitive decline. So it is a lifestyle habit. Physical activity may be recommended to adults with a mild cognitive impairment to reduce the risk of cognitive decline, but the quality of evidence is low, so the strength of recommendation is conditional. As a routine activity, quality of evidence is moderate and strength of recommendation is strong. So physical activity in those people with a normal cognition have a better cognitive result. But we don't know what is the optimal dose of the exercise. Does exercise have different effects on men and women? Does subtype of dementia matter as far as exercise is concerned? Please read this beautiful article by Alti in Practical Neurology, which has come in 2020. Now, what about treatment trials? People focus on amyloid hypothesis. So people say that why don't we have alpha secretase activators that might protect dementia, or beta secretase and gamma secretase inhibitors, or even degradation of beta amyloid can be reduced by or improved by neprilysin, cathepsin, etc., or beta shade breakers. And in order to reduce the aggregation, you have got drugs here and oxidative to combat oxidative stress. People, you put on antioxidants. GSK inhibitors, people have tried, and drugs to target on tau hyperphosphorylation, and even focusing on JNK and MAPK signaling to reduce apoptosis. Some people have tried NSAIDs and statins. Evidence is very, very poor. So what we have, multiple causes, multiple targets. We do have the risk factors. We know about beta amyloid plaques and hyperphosphorylated tau. People are trying with the beta and gamma secretase inhibitors or alpha secretase enhancers, but the results are very poor, no success. Anti-tau agents, sorry, no success. What we have is only cholinesterase inhibitors for control the presynaptic cholinergic failure and cholinergic deficit. So you give cholinesterase inhibitors, more acetylcholine is available. And antioxidants people try as an add-on. And to reduce the glutamate toxicity, we give memantine and antioxidants as an add-on for every condition, neurodegenerative or anything. So the drug development, what we know, acetylcholine inhibitors are there since long, late 70s, and it has gone on. NMDA antagonists, mid-90s. Then we have got some suggestion of some medical foods like Mediterranean foods. But the experimental treatments are antioxidants, anti-inflammatory agents, TAVO modifiers, mitochondria targets, fish oil, and others, cholesterol-lowering drugs, hormone therapies, and others. Approved drugs are donepezil, rivastigmine, galantamine, that you know, cholesterol inhibitors, memantine, and also the combination of donepezil and memantine. This is a beautiful article from Jeffrey Cummings. But what is the evidence? Mean global improvement over placebo is only 3, 4 to 4 points on the Adskog scale. That is equivalent to the naturalistic decline over 6 months period. That means you can reduce the progression, but you cannot stop the process. Most studies have been of short duration, 6 months, 1 to 3 years studies have been reported with the donepezil, and they suggest some benefits in the long term if you continue. But open studies suggest a possible effect of cholinesterase inhibitors on disease modification, but more data are needed before this can be confirmed. Cochrane review has concluded trials supported evidence of benefit in mild, moderate, and severe Alzheimer's. But a point will be there, that's 2 to 3 years. In a severe Alzheimer's disease, this is not going to have any benefit. So 2 to 3 years, you have to reconsider whether we have to continue or not. We do not know when to withdraw the drug also. Which particular non-cognitive symptoms may respond best to cholinesterase inhibitors? Though psychosis and apathy, they say there is a type 2 evidence. But regarding agitation, evidence is very, very thin as far as cholinesterase inhibitors. Trials show very small number needed to treat, between 3 and 7 in most cases. And NMTs are smaller with large doses, but tolerability is an issue. So, with the good safety and tolerability of newer cholinesterase, the small NMTs suggest they have a valuable place for the time being in the current management of dementia. Memantine is recommended for even moderate to severe dementia, but the problem is optimal duration of treatment with memantine has not been determined, and discontinuation of treatment should be considered when there is no therapeutic benefits. But the problem is why these treatments fail. These are some of the questions that we have to consider. Are we missing the target or spraying bullets without a direction? And personally, I feel so. Are we dealing with the multiple subtypes of Alzheimer's disease? I feel so. Do the failed trials targeting abnormal beta amyloid and tau hyperphosphorylation reflect a doubtful etiological hypothesis? Pathologically, they may be there, but they may not be the basic pathology there, the culprits there. That is something beyond. Do APP mutations cause disease by altering the generation of beta amyloid? Questionable. Beta amyloid may be there, but it may not have a cognitive decline in all people. Does beta amyloid employ tau to damage neurons? Possibly in some of the cases. Is soluble beta amyloid a toxic species? There was a talk for even 5 to 6 years, but it is questionable. Now, is it because of the disconnect with the time? Because the process would have started long back, but the the reflection, symptoms really start later. So there is a disconnect with the time. The disconnect with the quantity of the plates and the tangles, and disconnect with the anatomical location. Is it because of that the treatment trial fails? Probably so. Or is it because the drugs are given too late in the disease? Probably yes. Now, the four main pathological subtypes of Alzheimer's disease, which has come in a beautiful paper in 2020, Dementia Geriatric Cognition Disorders. The classical Alzheimer's disease 55%, that's called typical. Then limbic predominant, hippocampal sparing, and minimal atrophy type. Typical one, it is a multi-domain amnestic syndrome, frequent APOE4 genotype. NFT counts, neurofibrillary tangle counts in hippocampus and associated cortex, it is balanced. But most important, higher beta amyloid PET, if you do in occipital cortex, less in medial temporal parietal cortex. Limbic predominant, frequent APOE4, and mapped H1 genotypes, but TDP43 proteinopathy is frequent, and it is more in females, and severe atrophy of medial temporal lobe, which is not there much in typical Alzheimer's. Hippocampal sparing, it's a non-amnestic syndrome, but faster decline. Some of the variants of Alzheimer's, faster decline, and mainly predominantly in males. And the problem is mainly in frontal and parietal cortex. Minimal atrophy type, less affected by tau pathology, but beta amyloid, yes. So there may be multiple types. Reduced metabolism in parietal cortex, but there is increased small vessel disease. So neurovascular component is also there. And regarding the CSF levels of beta 1 to 42 and tau and ubiquitin biomarkers, there are classifications like ALO, ATIO, LEBELO, HARO, and ATURO. Depending upon the variation, I am not going to discuss here. So the new targets, new cholinesterase inhibitors and hybrids, new NMDA receptor antagonists and synaptic function modifiers, 5-HT6 receptor antagonists, gut microbiota regulators, anti-inflammatory agents, new ones, autophagic modifiers, circadian rhythm stabilizers, epigenetic target, PD inhibitors, immunotherapy, and TREM2 signaling, that is the new one which has come, and some other diets. Cholinesterase inhibitors, censorin and tolserin is supposed to have delivers more cholinesterase, and it is, tolserin is supposed to have 200-fold, and that ratio is 24:1. Supposed to be good, but we do not have evidence now. Nitidine and avicin derived from Xanthoxylum rigidium. It has got cholinesterase and monoamine A inhibition and beta amyloid anti-beta aggregation. And kelminthosporin from herbal, and methanosulfonyl fluoride and bombuterol derivative. These are all being tried in 2020 onwards. Heterodimers hybrids, tacrin donepezil combination, heterodimers, not the classical one. Heterodimers of tacrin and cuperazine or cuprin, tacrin and bifenthate, tacrin lipoic acid or lipocrine, tacrin trolox, vitamin E, epsilon, and carbazole, vasodilatic beta blocker, ferulic acid combination, donepezil with a partial serotonin subtype 4 agonist combination, donicopride, memantine and galantamine together, memantine, these are all heterodimers, and heterodimers of memantine and nitroglycerin, memantine and 6-chlorotacrin, and many other things, melatonin. NMDA receptor antagonist, which can have NMDA subproduct tau phosphorylation inhibition. They are under trials derived from Angeria ringophylla. These are on phase 1 and phase 2 trials. Recently, a new report in cell proliferation 2021, there is a role for AMPA receptor subunit glutamatergic A1 in synaptic plasticity, and beta reduces PSD fraction 95. So there may be a role of AMPA receptor agents. We do not know. Synaptic plasticity, some people are trying. Low dose levetiracetam as it a SV2A modulator, blarcamazine, sigma-1 receptor agonist, and M2 autoreceptor antagonist, pro-relusol. Bhaskar Mukherjee is so much interested in relusol. This is pro-relusol. It's a glutamate modulator is coming, and you have got a P38 MAPK alpha inhibitor supposed to be there, and other endonerpic, it activates sigma receptors. These are all 2020 and phase 1 to phase 2 trials. Probiotic gut microbiota regulators. China has approved GV971 oligomanate. It is supposed to be good for mild to moderate Alzheimer's disease. In November 2019, it has been approved by them. It has come in Acta Pharmacologia Sinica in 2020. Anti-inflammatory agent, cromolyn ibuprofen combination, mast cell stabilizer, and acyliragon, rage antagonist. And people say that Alzheimer's, they may have, the people with the bad dental hygiene can have, they may develop Alzheimer's earlier. So bacterial protease inhibitor targeting gingipain producing gingivalis, musnip tyrosine kinase inhibitor modulating muscle, even montelukast leukotriene receptor antagonist, pulmonologists use it, and now it is being tried to promote degradation of beta amyloid tau, rapamycin, methylene blue, a quercetin modified nanoparticle therapies. Circadian rhythm stabilizers, suvorexant. It is an orexin receptor antagonist. It has been suggested to improve cognitive impairment. We have to wait for the results. 5-HT6 receptor antagonist, SUVN 502, used as an adjunct to donaxicillin and memantine, is now under investigation. Now, regarding immunotherapy, almost all them have 100% failures. Aducanumab, monoclonal antibody, and amyloid vaccine, gantenerumab, solarisumab, and so many maps. But aducanumab, there were 2 studies. Emerge trial was negative, but Engage trial, they say beneficial. But so far, so till early 2020, the company is trying for a regulatory approval. So far, so it is negative. This, I think, the slides are not clear, but you can go through the journal Neurobiology of Disease. It was under press in 2020, 2021, it would have been published. Tau immunotherapies, failures. The reason is antibodies targeting more abundant pools of midbrain, mid-domain of tau, phosphoepitopes of tau, and conformational forms of tau may fare better in Alzheimer's disease population. So you have to still wait for that. And so far, so tau immunotherapy is failure. And you can go through the neuropharmacology 2020, it was under press. It will come. It would have come now, by now. Epigenetic targets or, sorry. Can I take 5 more minutes?
2 more minutes, sir, please.
Yeah.
Time up, sir.
Yeah.
Thank you.
HERT peptide vaccine, telomeric functions, people are trying, antisense oligonucleotide, RNA inhibitors, and many microRNAs are targeted, but these are under trials. PD phosphodiesterase inhibitors 5, 4, and 3, so far so results phase 2 and phase 3. Nanotechnology based delivery system, people are trying, we have to still wait. Neural stem cell therapy, it has been tried in murine Alzheimer's disease. In human beings, we have to still wait. Again, there are so many methodological problems. Diets, many diets people have talked, including epigenetic diet. And recently, 2021, I saw an article on 36-month live PD diet that is multi-nutrient clinical trial supposed to give good results. That if you give a good dietary approaches, you have to start early and you have to continue for a long time, including the Mediterranean diet. Caffeine, 65% reduction in incident AD, meta-analysis negative, no evidence from RCTs. Cocoa, chocolate, supposed to be good. Rajesh might like it, but evidence still poor, needs further studies. Curcuminoids, no definite conclusion. Garlic, our own thing in India, and no RCTs. Magnesium supplements, no RCTs. Multi-domain intervention, omega-3 PUFAS supplementation. We need again, and recently, this year I saw a Cambo medicine, Japanese, Hachimi Jogan, they are trying, they are recruiting. Resveratrol from grapes and red wine, get weight, beta carotene studies are underway. So again, I am asking the question, why did the treatment trials fail? Are we missing the target or spraying bullets without interaction? Are we dealing with the multiple subtypes? Do the failed trials targeting abnormal beta amyloid or even any other things? Whether we have to refine the etiological hypothesis and soluble beta amyloid toxic species questionable. Is it because the drugs are given too late in the disease? But most important, there is a disconnect with the time, disconnect with the quantity of the plaques and the fibrils, disconnect with the anatomical equation. So back to score one. In 1911, hello Alzheimer's. Alzheimer has told. So we have to come to the conclusion that the plaques are not the cause of senile dementia, but only a combining feature of senile involution of central nervous system, 1911. And he has told in 1911 again, I am therefore not able to make any final conclusion about the circumscribed form of senile brain atrophy, but I want to communicate my observation because they show the difficulties which still lie in the way of an interpretation of this result. Perhaps they will motivate someone else like Rajesh or Anukant or Bhaskar or Avinash with a new material to answer the question, still awaiting a solution. So if we could unfold the future, the present would be our greatest care. Thank you very much.
Thank you, Mohandas. As usual, you have raised more questions than you have answered. As usual, we are left scratching our heads with all the important questions that you have raised. As usual, the data has been presented is fantastic. Thank you for erudite presentation. And may I now shift to Dr. Anukant Mital for a very clinical, pragmatic presentation. Anukant Mital, as we know, is a professor of psychiatry in Mumbai. He is well loved by everybody. He is today the president of the Indian Association of Private Psychiatry. He is the face of private psychiatry today. And with a brief introduction, well-known face, may I now ask Dr. Anukant Mital to start the topic of very great interest to us clinicians, dealing day in and day out with the behavioral symptoms of dementia. Dr. Anukant Mital, please.
Right. Can we have the slide, please? Yeah. Okay. The first slide, please. The previous one. Yeah. So I'm basically going to talk about the non-pharmacological management of behavioral and psychotic symptoms of dementia. So if we think about what is the main behavioral and psychotic symptoms of dementia first. So the next slide, please. The first thing that we have to remember, as you have heard Dr. Mohandas speak so clearly, so concisely about the fact that the whole process of dementia, of Alzheimer's dementia, is constituting such a myriad, picture of so much of neuropathological damage, neuropsychological damage, uh, that we do not have still anything particular which can target and arrest or cure the progressive disease. It is a neuroprogressive disease. So we have to then shift. If we can't cure, then we have to shift to something where we can start talking about caring when we can't cure. Next, please. So the physician's vocation, as the traditional saying, is to cure sometimes, to relieve often, and to always comfort. We may be able to cure some of the diseases, but often provide relief, but always we are there to comfort the sufferers and the caregivers. Next, please. Why it is important and why are we talking about it today is because geriatrics will be a part of everybody's practice. According to statistics, those aged above 65, they are going to redefine now the elderly to as above 70, and people from 55 to 65, 70 are going to be called the mature adults. So, but aged above 65, which is the age at which we start thinking of dementia, currently already are 14% of our population and are going to rise by 2050 about 25%. As Dr. Mohandas showed in his first two slides, the numbers in America are measured in almost becoming 3 times in millions. And age above 55 will be 5% of the population, which definitely will have a higher percentage. As again, Dr. Mohandas showed that the higher percentage is between 75 to 85. So 33% of office visits now will now become 50% of office visits, which will be by people who are aged 65 and more, and they will account for about 1/3 of our health costs. Next, please. So this is very important for us. This disease of the elderly, of the more mature, the people who have been productive, who are responsible for our progress and our world that we live in now, are going to be dependent on us to provide a cure, which we won't be able to, but at least we can then work to provide them with something that is positive in the 4, 5 eyes that they have, provide them with a sense of independence, interest, give them some points of information, make them feel included, include an inclusive therapy, and include a lot of interactions with them. The negative aspects that they face is isolation, insecurity, the immobility because of the physical ailments and other problems, the instability because of the neuropsychological issues, the intellectual decline because of the neuropathological damage, the illnesses which coexist, the comorbid illnesses, the insensitivity of the caring atmosphere around them, the intrusion in their time and space because of their dependence, the incontinence, again, because of their illness, the iatrogenesis because of the myriad conditions for which they are taking multiple drugs, their inability to fight and to face up to these problems physically, mentally, emotionally, financially, and spiritually. And of course, the last part is the insanity, where rationality of their mind is lost. Next, please. So we are going to talk about the management of behavioral and psychotic symptoms of dementia, which Dr. Mohandas right in the beginning said that he calls them neuropsychological symptoms of dementia. So the basis of neuropsychological or non-pharmacological methods of treatment of these behavioral and psychotic symptoms are that caregivers must modify the environment or their own behavior, because the patient and his illness is not going to be modifiable much. They have to address any underlying or comorbid conditions which are contributing to the behavioral problem, the psychotic problem, maintain the environmental stability and the calmness of the surroundings, prevent major injuries and weight gain, maintain verbal and non-verbal interactions with the patients at a reasonable level of non-stressful, promoting independence, mediate the family stress which arises because of the patient's illness and incapacities and abnormal behaviors, and preserve the patient dignity at the same time. Next, please. So dementia, as we know, basically now very clearly consists of three parts. One is the decline in the activities of daily living, like caring for self, combing their hair, shaving themselves, tying their nadas, buttoning their shirts, wearing their shoes, tying the laces, and cognitive deficits where they forget, they have topographical amnesia, they forget who they are, they forget who they are living with, they forget the phone numbers, they forget the faces, they forget the names. And of course, the big thing that is coming is, next please, is the behavior and psychological symptoms, which is a heterogeneous range of psychological reactions, psychiatric symptoms and behavior resulting from the presence of the psychopathological process of the damage occurring in the brain of dementia. Next, please. So the importance of BPSD is for 2025, the numbers of patients who suffer from behavior and psychotic symptoms of dementia would approximately reach 34 million worldwide, and a majority of them would be in developing countries, of which we are one. And this will be a major health issue for us. Next, please. So in classical descriptions of dementia, if you see the dementia senile in 1838, Esquirol mentioned a condition which may be accompanied by emotional disturbances. Even Alzheimer, in a classic earlier 20th century case description of the disease, mentioned 4 symptoms of paranoia, delusion of sexual abuse, hallucinations, and screaming, which obviously were psychiatric symptoms of dementia at that time. Next, please. So the emerging recognition of BPSD has become only in the 1980s, when it was attributed to neurotransmitter or neuropathological changes, while others focused on personality contributions and psychological factors. It's clear that BPSD needs to be assessed as part of an evaluation of dementia. We cannot say that it is not part of dementia. And the chronology of this evidence is, next please, that in 1986, next please, 1986, the CMAI focused specially on behaviors such as hitting, pacing, and screaming. In 1987, the behavioral pathological rating scale of Alzheimer's disease, BEHAVE, focused on specific symptoms different from those seen in other neuropsychiatric disorders, such as delusion that people are stealing things, fear of being left alone and abandoned, and the fragmented sleep, which is described by Reisman. Next, please. In 1994, the neuropsychiatric inventory has frequency and severity scales for behaviors common to AD, also include scales for other dementias. The consortium to establish a registry in Alzheimer's disease in 1995, behavioral scale focused both on behavior and psychological symptoms, as reported by Tarriott in 1995 and 1996. Next, please. The basic statement that we can get, a consensus statement, came from the IPA, which is the International Psychogeriatric Association, one of the largest bodies, one of the trustees of which, I hope he is present here, Dr. Venugopal Jhamar, convened a consensus conference on the behavioral disturbance of dementia for basically 2 purposes. One, to review the current knowledge on behavior disturbances in dementia, and to reach some consensus of the definition, the causes, the description, and future research directions. Next, please. In 1999, the consensus group, consisting of some 60 experts from 16 countries, said symptoms of disturbed perception, thought content, mood, or behavior. Now, if you go back, this is exactly what any psychiatric or any psychotic symptom disorder consists of. that frequently occur in patients with dementia, as described by Finkel and Burns. Next, please. So they said a basic method of grouping, which is simple, is we talk about behavioral symptoms, which on the basis of observation include aggression, screaming, restless, agitation, wandering, inappropriate behavior, sexual disinhibition, hoarding, cursing, shadowing, etc. And psychological or psychiatric symptoms, which include anxiety, depression, hallucinations, delusions. And that is why a psychosis of Alzheimer's disease has been accepted since the 1991 conference. Next, please. Yeah. So if you look at it, the spectrum is basically psychotic symptoms, behavioral symptoms, and affective symptoms, which all combine together under the rubric of the psychological and behavioral symptoms of dementia. You may have them in different variances in various patients, where prominence may be in one of behavioral symptoms, in other may be affective symptoms, in other may be just plain hallucinations and delusions or misidentifications. Next, please. So the frequency is that can result in a lot of suffering, can lead to premature institutionalization, especially in a country like ours. I mean, coming from a city like Bombay, where space is at a premium, and most of the families, single families or two-generation families, can afford to live in a flat which is a 2 BHK or a 3 BHK. When they get a third-generation person who's suffering from dementia, who's having behavioral and psychiatric symptoms, who's basically creating a problem, premature institutionalization may be considered much more earlier. Increased cost of care comes in because you have to start treatment for the behavior and psychotic symptoms. And of course, many times hospitalizations in specific psychiatric nursing homes, significant loss of quality of life because of these patients having a restricted life because of their psychotic symptoms. And even his caregivers and family are restricted because of the instability and unpredictability of the behaviors. A large number of studies looking at the occurrence of these symptoms in nursing home populations have found to occur in up to 90% of the patients, which is obviously a bias because the patients who have these kind of symptoms are unmanageable at home and they end up getting hospitalized. Next, please. So when we say we look at a groups of symptoms, you may have apathy, person withdrawn, lack of interest or motivation. You may have a patient who's aggressive, who has aggressive resistance, physical and verbal aggression. You may have hyperreactivity in motor, walking aimlessly, pacing, trailing, restlessness, repetitive actions, perseverative actions, dressing, undressing in public, sleep disturbances, psychosis where they are hallucinating, their delusions, paranoid about their own relatives, about their own spouses, their intimate partners. They are depressed, sad, tearful, they are suicidal, they have low self-esteem, they have anxiety and guilt. Next, please. So, next, please. Yeah. So, signs and symptoms: perceptual, affective, as common, delusions as common as 20 to 73%, misidentification 20 to 350%, hallucination 15 to 49%. Affective symptoms can be up to, depression can be up to 80%. Again, leading to, as has been said previously, a diagnostic misfortune where you have problems, whether it is a depressive pseudodementia or is it dementia with coexisting comorbid depression. Then you have mania in 3 to 50% patients. You have personality changes, behavioral symptoms, aggression and hostility. Next, please. Next, please. So assessing the underlying need, there's a perception that people with dementia do not talk rationally. And that is why we have in Hindi or in India a language colloquial thing is ki wo to satya gaya. That means a person who has become old is talking nonsense or talking irrational, is thinking irrationally. It is contrary to caregivers' expectation as to what is appropriate for interests. For instance, a request for water may be discounted because they just had a drink. They may not realize that the patient is asking for a drink of water because they are again feeling thirsty. The person is unable to provide a complete description of what is troubling them when they experience pain. The caregiver is listening to literal rather than underlying message. patient may say that it is cold outside, while they may be feeling that they may be trying to convey that they are feeling cold. There are deficits in caregivers' communication skills. I would say there are deficits in the skills of communication between the caregivers and the patient. Right? Next, please. So untreated BPSD contributes to premature invalidation, increased financial cost, decreased quality of life, caregiver stress, stress to nursing staff in residential facility, and excessive disability. Next, please. Wandering and agitation have been shown to be the most enduring symptoms over a two-year period, as described by Devanand et al. Next, please. So these are symptoms which are worsening. These are the factors which worsen underlying dementia, especially drugs for all the coexisting diseases, for dementia, for the behavior and psychiatric symptoms. Many of the drugs which are used trying to control the behavior and psychiatric symptoms themselves produce akathisia. So they would cause cognitive disturbances. They would cause mood changes. So they would be contributing to the dementia. Emotional illnesses, metabolic endocrine disorders, which are very common, eye and ear problems like cataracts or hearing issues, nutrition, because these patients tend to get neglected and ender abuse, and ender neglect is very common. Trauma, because of their frail health and their physical restrictions, they may have a lot more trauma. Impaction and infections, which are very common because of their decreased resistance to infections and their general weakening conditions. And of course, drugs like alcohol or blood disorders like anemia can contribute to the underlying dementia getting worsened. So non-pharmacological therapy that we need to think of, we think of three categories I would like to talk of. One is standard therapies, which are behavioral therapy, reality orientation, validation therapy, reminiscence therapy. Then, of course, there are alternative therapies, which are there in some centers where there are some experts who can help patients improve their quality of life in dementia by doing art therapy, music therapy, activity, complementary, aroma therapy, bright light, multisensory approaches. And of course, brief psychotherapies like cognitive behavior therapy and interpersonal therapies, which may be beneficial. Next, please. So, non-pharmacological interventions focus on social support, recreational therapy, physical exercise, mental stimulation, and a variety of non-medicinal treatment options. As Dr. Mohandas said, that a large part of the Mediterranean diet of physical exercise, increasing the tone of the muscles, increasing the resistance, etc., are non-pharmacological interventions in dementia. But they help also in the behavior and psychiatric symptoms because they help to reduce the effective perception of the environment. Psychosocial interventions focus on new ways to help patient and family members cope with the cognitive impairment and memory impairment through counseling and educational programs. Next, please. So, strengthening ways to deal with cognitive loss may reduce functional limitations for patients with early stages of Alzheimer's disease before their disease becomes worse. Training and the use of memory aids such as mnemonics, etc., help patients feel less agitated, less irritated at their inability to remember and get their behaviors more under control. Cognitive therapy may help them again reach that stage with better control of their depression or negative cognitive distortions and fostering more adaptive perceptions. Behavior therapy targets family givers and patients indirectly by helping them to plan and increase present activities so that they can start doing activities which help them feel better and get positive feedback from the environment. Next, please. So non-pharmacological interventions would be cognitive, functional, and behavior side of dementia. Educational intervention for caregivers have the advantage of being safe and being demonstrated with psychoeducational and cognitive behavioral benefits, as well as being very practical. Next, please. So limitations are these, that patients in the upper age groups vary in their response. Treatment need to be individualized. Age is associated with decreased renal clearance and hepatic metabolism. Patients often take medication, so interactions and side effects are likely. Anticholinergic effects may worsen cognitive impairment and lead to delirium, where their behavior may be abnormal because they are delirious and not because they are dementia. Another group of problem drugs that may worsen cognition, including causing central nervous sedation. Many patients may appear to be depressed or apathetic or listless, while they're actually drowsy because of the medication they're being given, and also associated with diminished vascular tone, where a lot of patients may be unsteady in their gait, may feel dizzy, and for orthostasis and fall. Next, please. Top 10 behaviors, why we talk about non-pharmacological intervention. Top 10 behaviors that usually do not respond to any medication. One is aimless wandering, inappropriate urination or defecation, that is not only incontinence of urine and stool, but inappropriate urination, inappropriate dressing and undressing in different places, wearing the wrong clothes, wearing them the wrong way, not wearing them properly, or taking them off in the wrong situations. Annoying perseverative activities, vocally repetitious behaviors, hiding and hoarding. This is one thing that happens. Whether it is a sense of loneliness, whether it is a sense of separation anxiety, but things that they have kept since long. There have been, I have visited homes of dementia patients where a room has been filled with newspapers dating back last 5 years, and they're not able to dispose those newspapers because they are hoarding. Abnormal behaviors like behaving like hyperkinetic, pushing wheelchair-bound co-patients in nursing homes, eating non-edible stuff, inappropriate isolation of themselves, staying away from others, staying in one corner, sitting quietly, not interacting with people. And of course, if they are agitated and if they are needing restraints, tugging and removing restraints and creating a lot of issues in care. Next, please. So we need to plan early, middle, late, and terminal cares, issues, reorientation, enhancing cognitive functioning, assessing mental state and mood reorientation, facilitating communication, hydration, nutrition, etc., maintaining incontinence care, range of motion, skin care, pain assessment management, and comfort care. So in different stages of life, next please, of the patient's disease, we have to continue and change our plans accordingly to the disease. So BPSD may be secondary to physical problems related to active intrinsic to disease or a consequence or depression or delusion. For example, physical problems such as pain, infection, and congestive cardiac failure, etc., can cause a lot of problems which can be attributed only to dementia. Getting dressed, new caregiver, etc., can get affected because a patient is not used to novelty and it takes time for them to understand and comprehend and collaborate with a new caregiver. Their personalities may change over a period of time. And of course, if they have delusions of theft, fear, they are hallucinating, they hear people talking to them, they have a fear of being prosecuted or persecuted, and that creates a lot of problems for the caregivers. Where to use non-pharmacological? The symptoms that are more responsive are depression and apathy. If you do a lot of cognitive therapy techniques, a lot of other techniques like interactions and planning activities with them, wandering and pacing reduce a lot with non-pharmacological treatments, and activities like which are very irritative for caregivers like repetitive questioning or mannerisms also reduce. Some of the symptoms which are quick to respond are anxiety, agitation, stealing, and hoarding. Next, please. So where to use? Basically use for all ABC, activities of daily living, behavior problems, and cognitive decline and its consequences. Next, please. So in activities of daily living, you start with scheduling their bathing, dressing, eating, their toilet activity, their sleep, job involvement, that is in patients, involving them to go out for routine work, like especially if they are in homes, to send them out for routine works like working in the gardens or working in the gym or the hydrarium. Or if the patient is in home care and is capable of going out and doing routine activities like going and paying bills or going and getting the milk in the morning, those kind of things are good. Maintenance of home and related affairs, basically supervising certain things at home which are being performed by other people. Using a telephone, in the olden days, we used to say in India, very rarely does anybody, rare number of people in the population have telephones at home. But now I think most of the old people are dependent on the phone to keep in touch with their family members and also to keep themselves involved. And you can use that to also help their memory, etc. And to, of course, seek help. Next, please. Can we go to B, please? These are behavior when patients are, we have to target symptoms of loneliness, apathy, depression, anxiety, restlessness. As I said, wandering, running away, escaping. A lot of patients of dementia wander away. So there are simple non-pharmacological management techniques that you have to do is preventive methods like putting bolts on doors and bolts on windows, locks on doors from inside in the night while sleeping, keeping track, informing neighbors and security about the tendency of the elder walking away and having the need to be escorted back. Agitation, aggression needs to be assessed, and in the prodrome needs to be assessed and controlled and aborted. Eating problems, overeating, undereating, eating non-edible stuff like pica, disinhibition, vocal words, socially being disinhibited, being sexually disinhibited at home. As I said, in a closed single unit family, single unit structure where there are 2 or 3 generations living, for an elderly person to become sexually disinhibited creates a lot of problems. Hallucination, delusions, illusions are part of the behavior and psychiatric symptoms that need to be addressed. Next, please. And of course, cognitively, the attentional process, the language function and verbal abilities, the visuo-perceptual and visuo-construction, learning and memory, processing speed, their executive functioning, their abstract reasoning needs to be strengthened, their problem solving, planning, etc. needs to be assessed and addressed. And overall, their intellectual decline cannot be arrested, but we should adapt the environment to help them deal with the decline they have in the intellect. Next, please. So there's a systematic review by Bates and Boot et al. They tried 3 psychosocial interventions: counseling, reality orientation, and procedural memory stimulation, and evaluation of effectiveness in people with mild to moderate dementia. All 4 papers used controlled trial design, where one group received treatment intervention, the other didn't. Sample sizes were small, ranging from 19 to 28 participants. They suggest that reality orientation is an effective psychosocial tool for individuals with mild dementia, while for the other dementia, you would require more effective, what you call counseling and procedural memory stimulation do not appear to be promising. Next, please. So specific issues and practical applications. I think I have about 10 more minutes. Next, please. We will discuss environmental, behavioral therapies for dementia patients, cognitive therapies, caregivers burden, what and how we do. Next, please. So environment, a patient with dementia is no longer able to adapt. This environment may be adapted in a way to meet special needs.
So around 5 minutes, sir.
Okay.
Yeah.
Ideal environment should be non-stressful, constant and familiar. So talk about the physical, temporal, sensory and nutritional considerations. Next, please. So all intervention depends on the caregiver's availability, priorities, economics and willingness. And in India, we find the caregivers primarily are the female members of the family, and they are the ones who are constantly at home. They are the homemakers, or it is the intimate partners, that is immediate partner, the spouses, who become the caregivers. Therapists need to be understanding, need to be able to explain and associate and explain the experience. They use their experience in working with these patients. Common mistakes is the patients are shifted to a new place. The changes are positive for others, but not for the patient. Access is difficult for patients. They have poor exposure to nature. There are poor ventilation, noisy surroundings, uh, uh, wrongly placed mirrors, very frequent changes in the furnitures or rooms. Patients are shifted in nursing homes from different wards. But even at home, very often as the patient becomes more and more unruly or unmanageable, their rooms are changed, they're shifted to the balcony, they're shifted to another room, they're asked to sleep in the hall, or those kind of things start changing, and that leads to a lot of problems. Next, please. So the environmental changes include the bed being changed, the switches are not within their reach. There is no bell or way that they can call for help if they are immobile or if their mobility is affected. They have to climb stairs, and if they have physical problems, it becomes difficult for them to understand in their mind how they can climb stairs and how they can climb downstairs. The walls around them can be very difficult for them to sustain, because if they're very dull or very bright, they get affected by it. The temperature in the rooms where they are, in India, very few homes are air conditioned in the summer or heated in the winter, and they find it very difficult to cope. As the age grows, they find it difficult to maintain the body temperature to a certain level. Next, please. So we have to make sure that that happens. Temporal environment, sleep disruption is directly proportional to the severity of Alzheimer's disease, affected by both physical and temporal factors, including bipolar. So disturbed nighttime sleep, architecture, and daytime sleep. So we have to work towards getting them an adequate amount of sleep in a peaceful, quiet surrounding, which is a major problem in our communities. Next, please. Can we go to the next, please? So daily schedule should remain the same as much as possible. Change in routine should be very gradual. Physical activity, passive body heating should be there. There should be adequate exposure to light. Like for sleep hygiene, there should be a regular bedtime, regular time to rise. Bedroom should be used only for sleep. Now, this is very easy to say in houses which have multiple rooms and halls. But in India, when you have 1 BHK or 2 BHK houses, very often an unruly or an older demented patient may be confined to the bedroom the whole day, and that may be a problem. Regular meal timings, keeping it in a military precision, avoiding tea, coffee, nicotine, and stimulant, that is avoiding all types of stimulants in large quantities. Again, difficult because our patients are used to and addicted to tea, coffee. Probably nicotine, alcohol, of course, we can stop, but tea and coffee is something which is considered socially acceptable, and that becomes a big problem to reduce. Reduce evening intake, because then it stops them from having incontinence and wetting the bed at night. Minimize noise at bedtime. Easy to say. In a city like Bombay, it is very rare to find a house which is not next to the road, which is busy and noisy till late in the night. Next, please. Sensory considerations. We know in dementia there is decreased cognition, decreased visual and auditory perception. Pupils have decreased accommodation, decreased adjustment to darkness. The lens are yellowing, so perceiving of colors. They have cataracts and glaucomas. Their hearing is affected, so they get hallucinations. Patient may become fearful, anxious, or restless because they cannot see or hear their environment. That is why they need the caregivers to constantly keep them appraised of the environment, keep them a running commentary of what is happening around them, tell them it is getting dark, it is night, and they're going to switch off the lights, going to become darker. You're moving into an area on the street where there's going to be more noise, or you're speaking too loudly, you have to speak less. Those kind of things need to be explained to these patients in terms of their sensory status at that particular moment in time. Next, please. Remedies: avoid extreme of colors, no visual obstacles, provide visual clues, keep things at a fixed place. The worst thing you can do for a dementia patient is suddenly shift the furniture in the night or in the evening, and next morning the patient doesn't know, or not keeping a clear path to the bathroom. So the patient tries to go in the night and stumbles over newly kept furniture, not keeping a proper light in the room. Do not ask to perform tasks after sunset when their vision may be affected. Make such sufficient provision of natural light during the daytime. Easier said than done. Main thing is, if they're hard of hearing, don't speak if they can't see you, because many patients, by virtue of practice, learn to lip read. So if they can see you, they can read your lips and understand what you're saying. Talk face to face, clearly in the same pitch, and they may understand you better and respond to you. Of course, don't whisper in their presence. Very often we think that we don't want them to hear something and we whisper.
So 1 minute.
Yeah, they can hear us whispering, and that only exacerbates their paranoia. Provide a hearing aid if they have a sleeping disorder, a hearing disorder. Next, please. Nutritional consideration, as I said, they have weight loss, they need to eat time, hygiene, food hygiene. They may refuse to eat with others. Make them inclusive, get them to eat with others, may stop eating because of delusional perceptions, delusional and hallucinations. They lack an initiative to eat. They may have aggressive behavior where there may be caregiver burnout and there may be a poor feeding. They may be pacing and wandering, poor eating, overexertion. Next, please. Next, please. Yeah. Remedies: maintenance of time, food, and place, encouraging to eat healthy food, not pacify them. Do not give them a grief during eating. Give them brief snacks. Give them freedom and choice of what they would like to eat at their age. Next, please. Behavioral intervention: identify the problem, work jointly with caregivers, tackle one problem at a time. Identify how often happens, what happened, where does it happen mostly, in whose presence, what causes, what precipitates, what maintains, and try to maintain a diary of the behavior and psychiatric symptoms. Next, please. Identify before it happens and often target it so you can abort. Set realistic goals and plans. Evolve the patient as much as possible. Simple, achievable goals, step by step, tailored plans. Keep in touch. Work with caregivers to anticipate problems and abort problems becoming big. Treatment needs to be monitored and accessed to see whether it's working or not. Next, please.
So we are nearly at time up.
Okay, so
Yeah.
agitation and aggression, we can try a lot of other things like, but mainly what you do is you can increase their cognition by showing them photographs, audio tapes, video recordings of family members, sensory integration, social integration. Next, please. I think 1 or 2 slides are left. Right. Common mistakes problem: wandering, reassurance of where they are, give them a band on their hand or a necklace with their tag with their name and phone number printed on it, mentioning that call home, they are memory impaired, like we put for epilepsy patients. That is something we need to do, because many of these patients, almost 40% of these patients, if not controlled, will walk away and disappear and they will never be found. Next, please. So repeating questioning and mannerisms, you ignore, try to understand, you distract them, providing more of attention seeking, provide attention and behavior, and if necessary, proper use of lies to answer their question. Next, please. Inappropriate sexual behavior, accidental self-exposure and aimless masturbation is known, especially in the males. Undressing because the dress is uncomfortable or they're feeling too hot, or they are unaware that the situation which they are in or the place where they are in is inappropriate. Inappropriate handling of genitals, maybe because of itching, discomfort, or unitract infection. Quietly help them to get dressed, explain to them that this cannot be done here, and you have to be understanding and not get vexed about it. And that is the main thing. Excellent. Right. I think we can.
So we'll have to stop here. Yeah. Okay. I'm going to take up just amongst all the questions asked. I mean, we have around 5 or 6 minutes left for questions. So I'm just going to take up two questions. One is for Dr. Mital and one will be for Dr. Mohandas. For Dr. Mohandas, so the question is that, is there any evidence-based data to know the role of donanemab in the treatment of early stage dementia? And does it have any edge over our current pharmacotherapy?
Which one?
Donanemab.
No.
No.
To my knowledge, no. Evidence, everything is safe.
Okay. And so what is your drug? This is for Dr. Mohandas only. What is the drug of choice to treat hallucinations in patients with dementia?
Atypical antipsychotics, we give it, especially the first one is, I usually give, the evidence is basically clozapine. Clozapine is 12.5, it is available here, even less than that, we can titrate down. And there is no evidence for quetiapine, some people give it, but it's not going to be effective. In many cases, evidence is thin. Blonanserin, in my personal experience, blonanserin has got less extrapyramidal side effects and antichronic side effects. Though it is not US FDA approved, some patients I usually give in psychotics very low dosage, not even 4 milligram, even 2 milligram of less than that.
Right. The question is now for Dr. Mital. So it's a little long question. I'm going to go through it slowly. That as Dr. Mohandas mentioned, that there are multiple molecular processes implicated in Alzheimer's, and to know all these processes is extremely difficult. So tailoring drugs to an individual needs personalized agents, which we'll have to tailor as per each one's molecular biology. So do you think in the future we'll be able to address this conundrum?
Basically, we have to wait for the...
Sir, it's for Dr. Mital. 1 minute.
Okay,
thank you.
30 years ago, I used to watch something called Star Trek and Thunderball on TV, and we used to see them flip a phone and say, "Beam me up, Scotty," or they used to talk on those phones, and we used to say, this is never going to be possible. And we are doing all that now. Yes, anything is possible.
Yeah.
It is unthinkable that 10 years ago we would have thought, when we were teaching postgraduates, that we would be talking at a level where Dr. Bhaskar is talking, and people like me are sitting there wondering whether I need to go back and learn ABCD of molecular and genetic, So it's basically that if research has reached that level where they are able to identify the basic molecular structures of the transporter genes, etc., and work and tailoring specific drugs which would fit specific people, yes, excellent. But primarily, you have to understand one. All this is possible if you are able to diagnose. And as it is said, that by the time you diagnosed dementia, the damage has already taken place decades ago. So unless you have a test that, at birth, you diagnose and say this person is 90% likelihood of developing Lewy body dementia, and you start preventive therapies like Dr. Mohandas mentioned, of dieting, exercising, diet restrictions, lifestyle restrictions, etc., over a period of time, and try to reduce and abort the onset of the illness itself. Yeah. So it will have to be specific, tailor-made programs.
Yes.
Can I just suggest a line?
Okay. Yes.
If people are interested, 2020, Jeffrey Cummings has written an excellent paper. That is Drugs in Pipeline, 2020.
Okay.
And in that, for example, only 12 drugs, maybe sometimes maybe tried for cognition, and almost a dozen for behavior and psychological symptoms, and others are all disease modifying agents, phase 1 and phase 2. So we do not know where we are going. I think next year also, 2021-22, because that paper hasn't come out,
Correct.
2021. The same will be reflected. We will be confused, and it will add to the confusion because we don't know what we are dealing with. Thank you.
Correct. Correct. So the last question, and I think this we had decided that we will have one question which is an award-winning question from the questions which are asked, and I'm just trying to locate that question. 1 minute. The award-winning question is the question which has been asked as to why, yes, is by Dr. Manish Gupta. Why, and sir, this is for you, Dr. Mohandas. Why do we call them behavioral and psychological symptoms of dementia? Should we not call them psychiatric symptoms of dementia, because psychiatry includes behavioral, psychological, and other symptoms?
I will answer that. When I presented, I think 3 months back in a seminar, I have told that my term is not BPSD. It is neuropsychiatric symptoms of dementia, NPSD. And I do have my slide sets also. I have sent also to Venu. And I don't agree with the BPSD definitions. And it is NPSD, neuropsychiatric symptoms of dementia.
Right.
You are absolutely correct.
Yes.
Can I put my 2 bits in here?
Yes.
I think the word behavior specifically is because some parts of behavior are not psychiatric, like wandering. How would you classify wandering as psychotic?
Neuropsychiatric symptoms of dementia, not psychiatric. It is neurological dysfunction that has produced it, and the disinhibitory behavior is neurologic. And
that is true. I understand.
That is why neuropsychiatric symptoms of dementia, some of the neurological symptoms, you cannot do anything.
No. Mohan, I'm not disagreeing with that. What I'm saying is I'm disagreeing with the fact that why don't you call them psychiatric symptoms of dementia? Because wandering is not a psychiatric symptom.
I mean, you can use any term, but right? I am interested in neuropsychiatric. The reason being, we are dealing with a neurological condition. It is affecting the brain. I can explain what is happening in the brain, what is the mechanism behind it, and that is why I have put it neuropsychiatric symptoms of dementia. Even in my slides, why these people do it, I have got the imaging and the neural correlates. I have outlined it. Okay, that is the reason. Thank you very much.
And it's now my proud privilege to announce the winner of today's question, that prize, where the best question gets an e-voucher of ₹5,000 from Amazon, and that goes to Dr. Manish Gupta for this question which we asked Dr. Mohandas. And I think that brings us to the end of today's program. It's been an amazing program with 2 very erudite speakers who spoke on different facets of dementia. And most importantly, I'll reiterate again, it's a fitting tribute that we could at Banai pay to late Professor Dr. Charles Pinto. I thank Professor Dr. Mohandas for his talk. I thank Professor Dr. Anukant Mital for his talk. And I think our next talk is scheduled for the 13th of April on Tuesday. Details will follow suit. Thank you. Good night. God bless you all and wish you a great weekend ahead. Yeah. Thank you. Yeah.
Thank you.